So group B strep is normal in women's vaginas. It's called commensal bacteria. But if a baby is born by the vaginally and group B strep is in the vagina, it can infect the baby and make them very sick or even kill them. So we screen between 35 and 37 weeks. We treat for it so that group B strep is not there at the time of delivery. It often comes back. I mean, women have a tendency towards certain floral balance, and it's part of a normal floral balance in many women, over half of women. So you're like, wow, that's amazing. So just know that this is serious business. And if you happen to do the screening, you're going to do vaginal and rectal screening if you do the screening test. So complications in pregnancy, one of the big complications is preterm rupture of membranes. And if you have pH paper in family practice, you're going to notice that the pH is very high, which correlates with a blue color. Now there's swabs too, and some offices now have swabs that are non-numerical. They have a little bit of pH paper at the end that looks yellow, and you just stick it in the vagina, and if it turns blue, then you know they have, thank you very much, they potentially maybe have a fluid leak. Now sometimes semen will throw off. Usually semen will throw off the pH testing. So you always want to ask. And relations during pregnancy are normal unless are okay unless they have a reason they're not supposed to have relations. If they're very high risk for preterm labor, if they're on bed rest for issues in pregnancy, then usually that's contraindicated. But normally it's fine. So another test that can be done, although it's not done much anymore, is the Fern test. Whether you might see that on an exam question, I have no idea. But you take a swab from high in the vagina and roll it on a glass slide, let it dry, and then you look under the microscope, and just like on some of the windows of your cars, possibly this morning, you'll see frost on a window pane or frost on a car window, kind of a pattern. And that's called ferning. Placenta previa is a big concern in pregnancy. It's when the placenta is low-lying. It's close to the internal aspect of the cervical canal. So it's usually kind of right in this area here on that slide and right in this area here on this slide. Usually in early pregnancy, the placenta is there. And as the uterus grows, it moves up higher in the uterus. How cool is that? You don't think about placenta migrating, but they do. But if they don't, then when a woman goes into labor, the placenta can disconnect. And if it disconnects completely, what can that lead to? Abruptio. So that can cut off the oxygen supply to the baby, and if the baby's not delivered within a few minutes, you either have a dead baby or a compromised baby. So it's hugely important. If they're having painless vaginal bleeding, they're no longer your patient in primary care. They need to go to the emergency room and see the OBGYN on call. A vaginal exam should not be performed, even by L&D nurses, until they get to the emergency room. So C-section is the definitive way we resolve the problem for either condition. If it's on your exam as a question, what statements are true about placenta previa? We're looking for right answers. Number 1, painless vaginal bleeding. Yeah, let's circle that. Number 1. How about number 2, usually occurs in the second trimester? Yes. Sometimes third, but yeah, let's circle that one. How about number 3, no referral is needed unless it gets worse? That is absolutely incorrect. How about number 4, may progress to placenta abruptio? Yes, so 1, 2, and 4. 1, 2, and 4. And preeclampsia is very, very serious when it occurs in pregnancy. It's a hypertensive condition and actually is now linked to the development of being very high risk for diabetes later in a woman's life. So it's at least a 50% risk. Some research is suggesting as high as 80% now. So it usually does resolve after pregnancy, but not always. So just FYI, it can occur anytime after 20 weeks. And usually, though, occurs in third trimester. That's why you're always going to watch blood pressure and make sure it's not trending up. The definition has changed, so they're not going to really probably ask you about it on the exam. When there's flux, often they don't ask questions. But basically, it's new onset hypertension. So you can't go wrong with that aspect of the definition after 20 weeks. Now, Proteinuria, we always used to look for. It's been taken out as the essential criteria. It's now no longer required. Even edema. Almost every pregnant woman has edema in her extremities, but edema on the face and in the hands is very serious. We worry about that the most in this situation, or if they gain more than 2 kilograms of weight in 1 week. Kilograms of weight in 1 week. So end organ failure is possible and death is possible. So we take this condition extremely, extremely seriously. What are we going to do? Maybe not you, maybe not me, but that baby's going to get delivered. And until that baby can get delivered, that woman's going to be on bed rest. She's going to be on a very healthy diet, probably salt restricted, and in the hospital. Now, what are you going to notice? If you see any woman that's pregnant with blood pressure 160 over 110 or higher, they are not your patient. They go to the emergency room. If you're a long distance from the hospital, you're probably going to call an ambulance, and they're going to end up having to be in the hospital. So that's the reason why you want to watch that blood pressure. And if it's trending up, you're going to think about, even before it gets to 160 over 110, referring that patient to who? OBGYN, exactly. So when in doubt, you see the blood pressure trending up and they're heading in the direction of where you're going to worry. Even 140 over 90, they're no longer your patient. If that's a finding that's that isn't just a fluke, they are no longer your patient. So we use old medications that have a really good track record because we can't get the prospective randomized placebo-controlled trials. So you'll notice these medications are old, and that's because there are there's a great profile in terms of safety on them. So delivery of the baby is key. Now, do women run into problems with depression after babies are born? Yes, and it's more common than we thought. About 13% of pregnant women, that's a very high statistic. So it's a depressive episode within 4 weeks of delivery. Now, when do postpartum blues happen? They happen in the first 10 days. Usually they resolve by day 10 after the baby's born. So you're always going to kind of evaluate, where's this woman postpartally? And your scale, your depression scale, is the Edinburgh Postnatal Depression Scale. There's an app for that. You can pull it up real easy in your office. And where do they belong if they have a positive test? They need to see a therapist, and maybe you're a duly certified therapist, so then you just have to have them rebook an appointment. So check your knowledge, see where we're at here. According to the CDC, what is the recommended dose of folic acid for pregnant women? How about number 2? 1 milligram or 1,000 micrograms every day. Good job. How about what statement is not true about ectopic pregnancy? Number 1, the fallopian tube rupture may occur shortly after onset of symptoms. That's true, so let's not circle it. Number 2, symptoms typically occur about 6 to 8 weeks after last menstrual period. That's true, so don't circle it. How about number 3, serum HCG levels double every 24 to 72 hours. That's false. Remember, it's slow. If the pregnancy's in the tube, then it's a slow doubling. So we're looking for the wrong answer. Serum HCG levels double every 24 to 72 hours in an ectopic pregnancy, false. So let's circle number 3. Number 4, lower abdominal pain may be on right or left side. True. So the only wrong answer is number 3. You can tell what I think of wrong answer questions. So if you're that kind of person, you're going to read those questions and those answers how many times? 1,000 times. So folic acid is recommended prior to and during the first 3 months of pregnancy to prevent neural tube defects. Select examples of neural tube defects. How about cleft palate? No, let's not circle that. How about number 2? Yes. Number 3? Yes. Number 4? Yes. So you got 3 correct answers. 2, 3, 4. Good job. And a patient has a fundal height measurement of 32 weeks. She is probably about 32 weeks, exactly. So 32 centimeters should match 32 weeks. Number 3 is your answer. And how much wiggle room do you get? 2 centimeters or about an inch, under or over. Then they get referred. All right, good job. Number 3. And a uterine fundus should be palpable at 20 weeks where? The umbilicus, it's the only built-in landmark besides the ribs. So if they're at the umbilicus, they're 20 weeks. When they hit the ribs, they're probably ready to have their baby. So good job, number one, at the umbilicus. And this is just a nice graphic to show you the landmarks potentially. It looks like that woman has a lot of belly buttons. But it's a nice review slide. A 14-day postpartum patient has a positive screen for depression. What is the patient's most likely diagnosis? 14 days. Number two, postpartum depression. Good job, group. Excellent. And you're going to refer to a prescriber. Great job, everybody.